Hello. Hello.
Kenapa? Hello, good afternoon, Prof. Raina.
Hi. I just wondered if would you be able to change the date to today's date on my title slide?
Oh, okay. Okay, we will change it for you.
Thank you.
You're welcome. Prof. Raina, I am Uli. I'm going to be the Master of Ceremony for this webinar. And next to me is Pak Siswanto. He is going to be the moderator.
Okay, thank you. Nice to meet you.
Nice to meet you too.
Prof. Raina, maybe while awaiting another speaker like Prof. Chandra and also Mr. Panji, I just want to let you that because you have only 1 p.m. to 2 p.m. Jakarta time, so I think your turn you are to be the first speaker on the first session. Basically, first session is Prof. Raina and then followed by Prof. Chandra. And then we have a question and answer. And then we have the second session with the speaker of Mr. Panji, and because put is Panji, but the first is Panji Sumarto and the second is Panji Dewandara. So in case it's very important to anticipate if you can leave in the first session after question and answer in the first session, something like that.
Okay. Yeah, I've got I'm on a national committee, a government committee at 5 o'clock, and I've got to go for that meeting. Oh. That's why I can't stay. So that's 5 p.m. my time, which is 1.5 hours from now.
Okay, understood. Okay.
Sudah bisnis Pak. Nanti ada display sendiri di LED, Bapak bisa membaca yang sesuai urutan atau bisa Bapak di sini.
Prof. Chandra. Good afternoon, Prof. Chandra. Prof. Chandra already on board?
Yes, sir.
Oh, okay.
Tadi Fortuna yang belum. Lihat bang. Enggak, lead bangkas. Iya, lead bangkas.
So, Prof. Chandra, Prof. Raina, while we awaiting the other speaker. So again, I want to talk about the structure of this today's seminar. So basically, start from the opening session, and then that will be an address from the DG of NIHRD, National Institute of Health Research and Development. But unfortunately, the DG is escort the Minister of Health in Surabaya. So that will be represented by the deputy of DG. And then we enter into the webinar. The webinar will be divided into two sessions. So with in each session will be continued with question and answer. And then the first session, there are two speakers. As I already explained to the Prof. Raina, the first speaker will be Prof. Raina, because Prof. Raina only have one hour basically, and then followed by Prof. Chandra. And for each speaker, I will give 18 minutes. 18 minutes. And of course, I will remind the speaker 3 minutes before the due time. And then for each session, we have about 20 minutes for question and answer. Yeah. And the way that the participant raise the question is through the question and answer menu, and then I will be assisted by staff to screen the question, and then I will read that question to the speaker, to the speaker who the question to be addressed and what is the question. And the same also as the second session. And overall, it will take about 2 hours. Yeah, the today's seminar is about 2 hours. That's the structure. Maybe any something to be questioning, to be questioned. Prof.
So
Raina, Prof.
just one
Chandra.
thing passes. Just one thing passes. So I can be excused at about 2:30 Jakarta time, isn't it? I can leave the meeting at 2:30 Jakarta time.
Yeah. So there is different 1.5 hours between Jakarta and Delhi. Yeah.
Yeah. Let's just use Jakarta time because, as you said, it's 2 hours, so it will be until 3 p.m. So can I leave the meeting at about 2:30? Will that be okay?
That's right. So the reference is Jakarta time. Yeah. Yeah, agree. The reference is Jakarta time.
Halo.
Dr. Panji, hello.
Halo.
Are you already on board? Yeah, Dr. Panji Hadi Sumarto, is that right?
Yes, Pak, I'm here.
Okay, so we have 4 speakers here, Dr. Panji Hadi Sumarto, because in the other speaker is Panji Dewantara. So are you both brothers or?
Yeah, somehow.
It's Panji and Panji with D, Pak. Like Thompson
Oh,
and
yeah,
Thompson
different,
with
yeah.
T.
Yeah.
Okay. Oh,
Actually, we haven't met in person, but
okay.
we have already talked through
Oh, yeah.
Social media, ya,
social
Mas.
media. Yeah.
I want to explain to Dr. Panji Adi Sumarto. So basically, as I already explained, the webinar will be divided into two sessions, two parts. Yeah. So each part will be continued with question and answer. So the first part will be the speaker, Prof. Raina, and then followed by Prof. Chandra, and then continued or ended with question and answer in the first part, and then we move to second part. Yeah. So basically, Dr. Panji Adi Sumarto is in the second part, yeah, with another Panji, yeah, like this.
Thank you, Pak. Clear. Will I be sharing my screen, or will the screen be shared by the committee, Pak?
Okay. Basically, so far, I mean, those who register in this webinar is about 1,400 actually. So that's many. Yeah. Most, of course, from Indonesia, but some is from abroad. Yeah. Especially from the Philippines. I don't know why so many participants from the Philippines. Yeah. Iya pakai aja. Mana? Boleh ya? Belum mana?
Satu enggak ini? Satu, ya. Bukan.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Distinguished officials of the Ministry of Health, respected moderators and invited speakers, honorable attendants, good afternoon, ladies and gentlemen. In this beautiful afternoon, we welcome you all to attend this webinar hosted by the National Institute of Health Research and Development, Ministry of Health, Republic of Indonesia. For approximately 2 hours, we will gain knowledge and understanding on particular topic, focusing in the area of epidemiology and aspect of COVID-19, global trend and response, shared experience from different countries, and geospatial analysis and challenges. I would like to gently remind the audiences to value respect and courtesy the most during our webinar sessions. And I would like to remind all the audience about the link to the evaluation form will be given 15 minutes before the end of this webinar. Patiently stay tuned for it, as we will use the informations of the attendance field in that form for e-certificate purposes. Without further ado, I would like to invite the Deputy of National Institute of Health Research and Development to deliver the welcome remarks and officially open this webinar. Our distinguished deputy, Dr. Nana Mulyani, Master of Public Health and Philosophy Doctor, I invite you to talk, and so the floor is yours.
Good afternoon. Greeting, ladies and gentlemen. Thank you for participating in this event of the first international web-based seminar on COVID-19 with the topic of challenges of importance of understanding the epidemiology of COVID-19. Since the emergency of this disease, hundreds of thousands of deaths have been reported from countries around the world. In Indonesia, the positive confirmed figures stands the remaining fluctuated over time. As updates knowledge and strategies regarding COVID-19 is very important for every country to control the COVID-19. A part of our mission to promote local research and connects our researcher with international researcher and scientists. The National Institute of Health Research and Development, Ministry of Health of Indonesia is proudly hosting in this international webinar. We emphasize on epidemiology of COVID-19 for this first web-based seminar. In this session, the invited speaker will present focusing area on epidemiology aspect of COVID-19, global trend and response of COVID-19 experience from different countries in controlling COVID-19, geospatial analysis and challenges and measures for epidemiology indicators. We are grateful that we are able to conduct this seminar with the support from Dr. Siswanto, former DG of NIHRD, as a moderator, and for outstanding speakers, Professor Dr. Chandra Yoga Ditama from WHO CIRO office in New Delhi, Prof. Raina from University of New South Wales, Sydney, Australia, Dr. Panji Fortuna from Pajajaran University, and Mr. Panji Wibawa from NIHRD, Ministry of Health, Republic Indonesia. Also, for the attendance, particularly from Indonesia, as well as from Philippines, Australia, Canada, and other countries, I wish you enjoy this webinar. By the end of this speech, I announce this webinar to start. Thank you.
Thank you very much, Dr. Nana Mulyana, for your kind welcome. Now it's time for us to start the main sessions of this webinar. Our moderator for this afternoon is Mr. Siswanto. He is a medical doctor and also a master in health policy. He has an experience in health policy research and analysis. He is also a senior health policy analyst in Ministry of Health and also a former Director General of NIHRD from 2016 to 2020. Ladies and gentlemen, allow me to invite Dr. Siswanto and pass these sessions to him.
Thank you, Ms. Uli Adi. Yeah. Distinguished speakers, my dear all participants, I am very happy here in this webinar today. So this COVID-19 pandemic, I think, has accentuated that infectious disease has no border, affected any country, no matter developed or developing country. Therefore, to overcome COVID-19 pandemic, of course, we need partnership, we need collaboration, and we need also share experience. This international webinar will be conducted in serial event. Today's webinar is the first series, and today's webinar take the themes, the challenge and importance of understanding the epidemiology of COVID-19. We are very pleased to welcome our speaker, nationally and internationally. We have Prof. Chandra Yoga Aditama from Southeast Asia region, WHO, and Prof. Reina McIntyre from UNSW, Sydney, and Dr. Panji Fortuna from Pajajaran University, and Panji Wibawa Dewantara, PhD from Indonesian and HRD. Let me explain regarding the structure of this webinar. The webinar will be divided into two sessions. Each session is with two speakers and continued, of course, with question and answer. And basically, we have 2 hours. So then the allocation of question and answer is about 20 minutes. So in that case, I would give each speaker for presentation about 18 minutes. So I will remind the speaker 3 minutes before the due time. As Prof. Reina should leave at 2 p.m. Jakarta time, due to another agenda, so the first presentant will be Prof. Reina and then continued by Prof. Chandra. Dear all attendee, so if you have any question, you can write in the question and answer menu provided by Zoom application. You must write your name, of course, to whom the question is to be addressed, also the question itself. Okay, so the first speaker of the first session will be Prof. Reina. Prof. Reina is a professor of epidemiology in the UNSW, Sydney. And Prof. Reina will talk about the COVID-19 updates, transmission, herd immunity, exit strategy possible? That's a good question, actually, based on the immunity. I think by the sharing experience from the Australia, we can take some point of best practice and lesson learned. I think it's a good thing. So, Prof. Reina, please, time is yours.
Salam alaikum, distinguished dignitaries from the Ministry of Health and participants. Thank you for inviting me. I was asked to talk about the Australian experience. Should I share my slides from my computer or will you put them up there?
The organizing committee will, yeah. So okay. from here. Yeah.
So we'll just go to the next slide. That's just my disclosures. Next slide. So this just summarizes the situation in Australia, and we are very fortunate really to have brought the disease incidence down to a very low level with a combination of extensive testing. So the Australian testing rate has been one of the highest in the world, and very strong border control measures and good surveillance to find new cases, contact tracing, quarantine, and so on. we had the peak of our epidemic at the end of March, and then really coinciding with closing of all the international borders, the cases started to drop. Over 60% of all the cases that we saw were imported through travel or related to travel. And if you look at this graph on the right-hand side, it shows you that only a small proportion were community transmission with unknown origin. So the majority of the cases still, we could identify where they got infected, which means that we had a good handle on the epidemic. The map there shows you the number of cases by state, and New South Wales had the most number of cases, followed by Victoria. The graph in the middle panel, second from the bottom, shows you the age distribution, and this is consistent with several other countries that have done extensive testing. And the important point is that very high level of transmission, or the highest level, seems to be in the young people in the age group 20 to 29 years. They don't get as severe the disease, obviously, because the graph at the bottom there in the center panel shows you that the deaths are very much in the older age groups, but the cases were dominated by the younger age groups. Next slide. So there's an interesting relationship between case fatality rate and the number of ICU beds per 100,000. People die typically of respiratory failure. So if you're unable to provide ventilation, then the case fatality rate goes up. And we see that the highest case fatality rates were in countries like France, the UK, Italy, Spain, and Sweden. The US actually didn't have a case fatality rate as high as those European countries because the rate of ICU beds per 100,000 population was extremely high. So the number at the top of each bar is the rate of ICU beds per head of population. You can see that the United States has the highest. So Australia did not have a very high rate of ICU beds. We were similar to Italy. That's us at the end there. But we more than doubled the ICU bed capacity in preparation for the pandemic, and we managed to stop the epidemic effectively with the travel bans. So we were never in the situation of the health system being overwhelmed. Next slide. This is the same countries in the same order to show you that the number of cases was also very different. We all know that the United States has had the most number of cases, but their case fatality rate was not among the highest. Next slide. So really the pillars of epidemic control are, firstly, case detection. And for that, we really need testing capacity, both testing capacity and strategy. And once cases are identified, they need to be isolated, whether it's home isolation or in hospital. It's the second pillar is contact tracing and quarantine, and this has been shown to be highly influential. Contacts are at the highest risk of becoming infected or being infected, so quarantining them during the incubation period reduces that risk of transmission from contacts who become cases. And there's now a lot of evidence that a large proportion of transmission is asymptomatic, that somewhere between 20 to 50% of all infections are asymptomatic. Some of those people will be pre-symptomatic and some will never develop symptoms, but they can all spread the infection. And that's why the case detection, the contact tracing are so important. And with the contact tracing, my belief is that all contacts, whether they've got symptoms or not, should be tested because of the high risk of asymptomatic transmission. Travel bans are the other pillar, followed by social distancing, which is a range of measures which can vary from just asking people to maintain a physical separation of 1 to 2 meters to entire lockdowns. I don't think whole country lockdowns are necessary. South Korea showed us that you could do a targeted lockdown and still get excellent control of the disease. So they only ever use the lockdowns in the affected areas. And then vaccines or drugs, we don't have those yet. And universal face mask use is the other important intervention, which probably can make a big difference, particularly while we don't have a vaccine. Next slide. So this just shows you, this is from a paper in the Lancet by Roy Anderson. The red curve is the unmitigated epidemic. And then when you introduce social distancing, you can flatten that curve. So you reduce the total number of cases, and you also reduce the total number at any one point in time so that you do not overwhelm your health system. However, the caveat to that is that once you suppress disease with these measures, if you lift those restrictions, you will get a resurgence of disease, but to a lower level than what it was before. So managing the pandemic is going to take a balancing act between implementing interventions, relaxing them, and then putting them on again when cases start to increase. Next slide. This just shows you that issue about the health system's impact. So if you just look at the red graphs on the right, it shows the black line is the total ICU beds, and the dotted line is the available ICU beds that are not occupied by anyone. And you can see that in the unmitigated epidemic, you're going to by far exceed your capacity to ventilate patients. Whereas if you apply your distancing measures in the graph at the bottom, you still exceed your capacity, but not by as much. Next slide, please. This shows the impact of a range of different measures on flattening the curve, the unmitigated epidemic at the top, closing schools and universities, case isolation, household quarantine, and then using all of those measures plus social distancing brings it down the most. Next slide. This is just looking at what happened in China. So the lockdown of Wuhan began on January the 23rd. And you can see that within one incubation period, which is 2 weeks to February the 6th, you start to see a decline in cases straight after that lockdown. It was very dramatic. They actually started releasing the restrictions on February the 9th, which is only a few weeks after the lockdown started. And they gradually released those restrictions over the next several months, and they did not have a major resurgence. Yes, they're seeing an outbreak in Beijing at the moment, but they've still kept the case numbers at manageable levels. So this kind of lockdown moved them from a situation of having to deal with thousands of new cases each day to only having to deal with hundreds or less than 100 new cases a day, which of course is much more manageable and allows you to keep things under control. Next slide. So in Australia at the end of March, we were faced with, we had not closed all our international borders. We only had the border to China closed. And we were having this surge in cases in Korea, Italy, Iran, France, Germany, and Spain. So while we began implementing lockdowns in the first 2 weeks of March through to the 19th of March, and really, really flattened the curve as a result. Next slide. This is just to show the relationship of the evacuations from Wuhan. At that time, we were only testing people who had symptoms, right? So when people were evacuated from Wuhan at the peak of the epidemic in China, we only tested people with symptoms. And if some of those people without symptoms went back in the community and set off chains of transmission, then that could explain the surge in cases we started to see towards the end of February and in March. We also had evacuations from the Diamond Princess ship, which also corresponded with a surge in cases in early March. Next slide. This is just to show you the relationship of these different travel-related events to cruise ship events and the evacuation from Wuhan with surge in cases. And the blue arrow shows you that within 2 incubations of the travel bans, the curve has gone right down. Next slide. Interestingly, we had 15% of all our cases were linked to cruise ships. And that was largely the Ruby Princess, where people were allowed to disembark without testing before the test results came back, and particularly in the state of New South Wales. Next slide. This just shows you using the doubling time instead of the R0, looking at the doubling time as an indication of how well disease is being controlled. And this was in March, and you can see that Australia, the doubling time was sharply increasing in red, whereas in Japan, it was coming down. In China, they just got it right under control, so there's no data after the end of February. Same with South Korea, but you can see it rising in all those other countries. Next slide. So we looked at the impact of travel bans. First of all, what we did was we looked specifically at the impact of the travel ban on China, which we implemented on February the 1st, which was right near the peak of the epidemic in China on the sharp upward part. And the red curve is what cases were notified from China. Using some serological data that came from the Japanese testing of people who were evacuated from Wuhan, we estimated that the true size of the epidemic was the blue curve there, of cases that were probably milder and not reported. Next slide. And then we looked at what would have happened if we did not put that travel ban on China on February the 1st. The blue curve is what we did see with the travel ban, and the red curve is without the travel ban. So you can see that we would have had a much bigger epidemic with the travel ban. So at the beginning of March, we had about 50 cases in Australia. If we estimated that if we did not use that travel ban, we would have had more than 4,000 cases at the beginning of March. Next slide. And that's just showing geographic hotspots in New South Wales, which we think are related to some of the cruise ship outbreaks. Next slide. Just to mention that in many countries, they've done population serosurveys to try to see how widespread the infection is, and it's ranged from 2% to 20%. So in New York, it's about 20%. Next slide. That was the data from the population serosurvey from Iceland, which that's just to look at the age distribution. So really it is those young people and young to middle-aged people where the majority of transmission is happening, and it is less in children under the age of 10. Next slide. So the biggest challenges of COVID control is the substantial transmission in the pre-symptomatic and asymptomatic phase. It seems from the viral shedding data that the highest infectiousness is in the 48 hours prior to symptoms beginning and in the first day of symptoms. Also in mildly symptomatic people, there's also growing evidence of airborne transmission, and we only have non-pharmaceutical interventions for control. Universal face mask use, it's been shown in modeling studies, can flatten the curve even if the mask is only 20% effective and worn by 50% of people. Next slide. I might skip this in the interest of time. Next slide. Next slide. So this is just that viral shedding data from he et al. In Nature Medicine. And really it's showing you that the highest viral load is very early in probably just before symptoms start and on the first day of symptoms. And then it declines quite a lot, which is bad for disease control because it means that unless you catch people before they become symptomatic, you're not going to be able to stop those transmissions unless they're wearing a mask or social distancing. Next slide. This is the same study just showing you the possible distributions of the infectiousness of COVID compared to influenza. So we know with influenza, there's a little bit of pre-symptomatic transmission, but it seems to be much, much more for SARS-CoV-2. Next slide.
Prof. Rainer, 3 minutes more. Yeah.
Okay, I've just about finished. This is the next slide, a serological testing of, PCR testing of pregnant women presenting to an obstetric service. And they actually found 15% of people had SARS-CoV-2 and the vast majority of them was asymptomatic. Next slide. Next slide. And just to finish off, there's actually a huge body of evidence now that there is aerosol or airborne transmission. The idea about droplet transmission is based on very old data that has been shown to be incorrect. Probably there's more continuum of aerosols and large droplets in human respiratory emissions. Next slide. This just shows that the distance, that horizontal distance that droplets can travel is usually much further than 2 meters. So that 1 to 2 meter rule is not based on evidence. Next slide. Next slide. This is just showing the efficacy of medical masks and respirators against respiratory infection in healthcare workers. N95 respirators are more effective than masks. Next slide. And this is a study from Hong Kong that showed that coronaviruses are more likely to be airborne than other viruses. And if you put a surgical mask on, you stop the transmission. Next slide. Next slide. And this is just showing how much you can flatten the curve with wearing masks. So with no masks, that's the blue curve. With maximal mask wearing, you can barely see the curve. Next slide. Next slide. Next slide. This is just a really important study that's just been published in EID, which shows that viable virus can be found in the air 16 hours after it's aerosolized, and that SARS-CoV-2 is more aerosolized than SARS or MERS. Next slide. And to finish off, I think an exit strategy is going to be very, very difficult. This study shows that we're going to likely see periods of surge and decline where we're going to have to use lockdowns and other measures and then, relax them and then put them on again and manage the situation with this on-off strategy for at least a year or maybe longer, depending on when we can have a vaccine. Next slide. And just to finish off, I guess, for Indonesia, testing and case finding, enhanced surveillance, contact tracing and quarantine, social distancing, travel restrictions, face masks, and focusing on controlling infections in the kampungs, which are a very high risk setting. Next slide. So thank you.
Thank you, Prof. Rainer. I think it's a wonderful presentation explaining the pattern of epidemiology of COVID-19 across the world, and then make a correlation with the intervention of the respective country and offer a number of effective measures like face masks, physical distancing, and so on. For the participant who raise comment and question, please write in the question and answer menu. Now we move to second speaker, Professor Chandra Yoga Aditama. Professor Chandra is a senior advisor for EMR, publication and documentation. Also now is an acting director of communicable disease in Southeast Asia region. Prof. Chandra will speak about the readiness is the key to detect and to combat the spread of COVID-19. I think that's interesting from the regional and global perspective. So please, Prof. Chandra, time is yours.
Thank you, Pak Sis. If I can get my slide on the screen, please. So first of all, I would like to thank the organizing committee for inviting me to attend this important webinar. And I also like to congratulate NIHRD Indonesia for having this international webinar, which I saw attended by so many people, not only from Indonesia, but as well as abroad. I also heard that this is not the only international webinar, but it will happen again in the future. So congratulate NISRD, since I'm a part of NISRD anyway. So colleagues, ladies and gentlemen, I will discuss the COVID from the beginning until the possibility of post-pandemic. Possibilities, because of course we do not know. So this first slide show you the first report of the China government to WHO China country office. It was first reported on the 31st of December on 2019, and it was already in WHO website on the 5th January 2020. Of course, at that time, there's still a pneumonia of unknown cause. We do not know the cause at that time. And as you remember, as in the next slide, it was the next slide. It was mentioned that it began in this seafood market in Wuhan, even though later on there are several animals that said could be related to COVID. So begin on the 31st of December 2019, and now next slide. You must follow already now number of cases in the globally is more than 9 million people. So this is the data of 2 days ago. This is still 8 point something. And you can see country by country number of cases reported in the last 7 days. So this is not the whole cases, but case reported in the last 7 days. So the darker the color is more cases reported in the last 7 days. Next slide, please. You may know that WHO in the world is divided into 6 regions: Africa, America, Eastern Mediterranean, Europe, Southeast Asia, and Western Pacific. So based on this slide, you can see as per WHO region, the most cases are in American region, and number 2 is in European region. So this part of the world is Southeast Asia, but the definition of Southeast Asia of WHO is a little bit different with the Southeast Asia for ASEAN, for instance. So some of the Asian country, even Australia, is under the Western Pacific, and some are in the Southeast Asia. So if we add those two, Southeast Asia plus Western Pacific is about 800 something. So I mean, compared to globally, is still I think number 3 or number 4. Next slide, please. So this is the epidemiological pattern of globally. You don't have to go into the region by region, but you can see how is the pattern going up, and then the trend is the slope is not that high, but later on big high again. We can compare this one with Southeast Asia pattern later on. So this is the global. Next slide. And this is the Southeast Asia Regional Office. So you can see the difference between this pattern and the previous pattern. As I mentioned earlier, the Southeast Asia region of WHO is different with the Southeast Asia, for instance, ASEAN that we know. In the next slide, behind me, there are flags of, can I have the next slide, please? So those flags are no, okay. So these are the country of Southeast Asia Regional Office. So Bangladesh, Bhutan, Korea, India, Indonesia, Maldives, Myanmar, Nepal, Sri Lanka, Thailand, and Timor-Leste. So the trend is like this. It's little bit, not a little bit, it's different with the global trend. And if you want to see country by country, next slide, please. This is country by country. Since this is from Indonesia, so you can see on the left, the blue one is Indonesian trend, I mean line. Of course, it's much less compared to India, but India population is also 1.3 billion. And on the right graph, you can see that Thailand is basically already more or less under control their outbreak. So number of cases is very limited in this couple of days or even couple of weeks. Next slide. And this is the graph. You can see that is Indonesia is on the upper right. The blue one is number of cases, and the black one is death. You can compare Indonesia with Bangladesh or India or even Thailand below. So Thailand is going up and then going down. So the Indonesia, India, and Bangladesh is still going up. And again, the black one is the death. And the other part of Asia, next slide, is this one. So the Philippines is like that. And Korea, it's already mentioned by previous speaker, they more or less can control their outbreak. Is going up and then going down. Of course, China, we know the situation, and then the direct neighbor of Indonesia, Malaysia, is like that, as well as Singapore. So you may know that Singapore, they perform what they call circuit breaker, and now they ease that circuit breaker, and now it's in the phase 2 of circuit breaker easing. So and not as tight as earlier. Next slide, please. Symptoms, everybody know, fever, shortness of breath, cough. Next slide. And this is the diagnosis, of course. Next slide. And you all know that for WHO, we recommend the RT-PCR. Why I put this slide? Because I know the NISRD is one of the most important laboratory who perform RT-PCR in the country from the very beginning of the outbreak, even until now. So next slide. This is the laboratory diagnosis. Next slide. And we also know that most of the cases are mild, but only some are in severe cases. This is just an X-ray of the cases in China at that time. So the left one is normal X-ray, and the right one, and even below right, is a very severe cases. You can see the pneumonia in almost all of the lung. So again, this is the case of China at the early of the outbreak. Next slide, please. For the treatment, these are the one that mentioned in the WHO recommendation 27 of May. So you know that now WHO having the solidarity trial, almost 90 countries joined the solidarity trial. As of now, we still have 4 arms, but it will reduce to 2 or 3 arms in the coming days. But anyway, so all of these medication are still under trial. So still under trial, and you follow various development on the journal of this medicine. Next slide, please. I'm talking a little bit about lockdown. Next slide. For in case of WHO guideline, we mentioned that lockdown is a part of public health and social measure. And if you can read the last paragraph right below, so the decision to tighten or loosen the reinstitute of public health on social measure should be based on scientific evidence and real-world experience, and take into account other critical factors such as economic factor, security-related factor, human rights, food security, and public sentiment and adherence to measure. So this is not a simple decision to say tighten or loosen. So, but WHO, of course, making a recommendation in terms of public health. Next slide. This is the 6th recommendation to adjust public health and social measure, or to adjust PSSM. So the disease transmission is control, sufficient public health, etc. So these are the 6 criteria. And if you want to make it more precisely, next slide. These are the 3 criteria. I'm sure most of you already read this guideline, because there are specific criteria for epidemiology, for health system, and for public health surveillance. Next slide, please. So at the end of the day, so if you want to tighten or loosen the lockdown or public health social measure, so it should be based on the local epidemiological analysis. So this one should guide the action of new normal of the COVID world. Next slide, please. So I just would like to mention that since we are very busy with COVID, we have to remember that there are a lot of other diseases in the world that we have to take care. Just go to the lower paragraph. It's mentioned that during the Ebola outbreak, the increased number of deaths of those diseases are exceeded the deaths from Ebola. So please make sure that other public health problem also taken care properly, despite our main priority of COVID. So there are so many communicable diseases has to be taken care, including immunization while we are taking the COVID, but not only communicable diseases. Next slide, please. Also the non-communicable diseases, because health services might be very busy to COVID, and people could not come to the hospital for taking care of their NCD, for taking for check their hypertension or diabetes. So we have to take be sure that the problem of communicable and non-communicable diseases are properly taken care of while we are taking this COVID hard situation in the country. Next slide. We know it's not only about disease, but also about stigma that has to be taken care of. And this stigma sometimes is also become an even bigger problem than the taking care of the disease itself. Next slide. Just show you one of Indonesian. So these are the countries that already has no new cases for 14 days. These are data, I think, from a week ago. So this data is changing from time to time, of course. But this is kind of our hope. The country could have no cases for more than 14 days. And for this one, then we will go to the next step of the pandemic, the post-pandemic. Next slide. I will begin So what will be our thinking? How can we imagine the global health in the post-pandemic world? And is there a place of artificial intelligence or other? But so let's begin the remaining 5 minutes with the post-pandemic situation. Next slide. I begin with this is the one WHO has for phases of pandemic, post-peak pandemic and post-pandemic. But this is for H1N1, not for COVID, of course. So for H1N1, we divided pandemic into 6 phases. Phase 1 to 3, that is animal infection, predominantly. Phase 4 is sustained human to human. And phase 5 to 6, widespread human infection. Again, this is for H1N1 influenza. And after that, a post-peak. But in the post-peak, it is clearly mentioned down there. Please beware or caution of the possibility of recurrent event. And as you know, for H1N1, then become an ordinary influenza. So it is mentioned that this is activity at seasonal level. This might not be the case for COVID, of course. Next slide. This is just an explanation of those 6 phases. I will not go into detail. Next slide. Just to remind you, the H1N1 swine flu 2009 number of cases might be very big. It is mentioned that estimated 11 to 20% of global, and the deaths could be estimated about 284,000. It lasts for 19 months during 2009. Next slide. And at the end of the pandemic, then WHO recommend the post-pandemic period. We can see for the next slide what is the content of the post-pandemic period for H1N1. The next slide, please. So it is clearly mentioned here in the green one. For a post-pandemic period for H1N1, it will continue circulate for some years to come. We will see what happened with COVID, but this is H1N1. Number 2, the blue one, there will still be many questions. I'm sure this is not only for H1N1, but it will also the same for COVID. So that's why the red one below, continued vigilance is extremely important on the post-pandemic event for H1N1. I believe it will be the same for COVID-19 as well. Next slide. So what will be the post-COVID-19 scenario? Of course, we do not know quite well, but it will depend on the medicine as well as vaccine. Those are the 2 important factors besides the other important factor as well. And for treatment, next slide. As I mentioned, we are still in trial. Usually it will take a decade or more, but we use the drug that already exists. So that is one of purpose of the solidarity trial, to see the efficacy of drug that already exists. This is about medicine and about vaccine. Next slide. This is just next slide. This is the vaccine. The issue for vaccine is not only when can we find the vaccine, but also should be, as mentioned in the Lancet, should be COVID-19 vaccine for all. Everybody who need it should get the vaccine. Not only vaccine available but not available. I mean, discovered or not discovered, but should be available for all. Our neighboring countries, Singapore, already mentioned that every Singaporean who needs COVID will get one becomes available. Next slide. And you know, based on the previous, this is the draft landscape of candidate vaccine in WHO website. today, I mean, I checked yesterday, is also still 10 candidate vaccine in clinical evaluation and more than 100 in preclinical evaluation. So this is 9 June, but yesterday is almost the same. Next slide. And we know based on the previous experience, it took so many years to get the vaccine. Hopefully for COVID, it will not be the case, but we do not know. We heard that some companies saying that it will happen in the 2020. Somebody even said late 2020, but based on other experiences, this is the years from disease, virus discover and vaccine. So many years. Next slide. And even, next slide. Even there's still no vaccine for HIV, no vaccine for malaria. There was a vaccine for dengue, but then there was some problem of that vaccine. So there are so many issues on this vaccine. But hopefully we can get the vaccine to be able to go to the post-pandemic situation. Next slide. Also, Indonesia have this problem. New post-pandemic baby boom might be happen. We do not know. Maybe it's due to lockdown or other situation. But anyway, so this is the situation. Next slide. So, as a conclusion, for now on, during this time, there should be a new way to deliver care while limiting visits to health facilities, because health facilities are overburdened with COVID, but other, as I mentioned, other health problems should be taken care of. So there should be a new ways to deliver care while limiting visits to health facilities. And I would like to stress again that we have to ensure that essential health services should continue even as we fight COVID-19. Immunization should be there, okay? And that is the important part. No one is safe until everyone is safe. Next slide. So I do not know whether we are in the end or whether we already see the light at the end of the tunnel, but we will see what happened. But whether we will light the end of the tunnel or not, it will depend on various factors as the next slide. Number one, how is this pandemic evolve? Will it be flattening, going up, recurrent, etc.? So this will we have to see the evolving of this COVID pandemic. Of course, many problem has to be taken into consideration. Second part, whether a new medicine or not new, a medicine for treatment and vaccine for preventing is available soon or not soon. Number three, everybody now talking about new normal, but there might be a new normal for now, where vaccine is not yet available and medicine is not yet available, but there could be also a new vaccine for the future time, because maybe even there is a medicine or even there is a vaccine, there should be a new normal situation that people has to live with. And of course, if the pandemic already going down, there should be an evaluation for the post-COVID pandemic. And I have to remind all of us that we have to prepare for the next pandemic anyway. So because there will be a next pandemic, like this pandemic and previous pandemic, usually after pandemic, then people tend to forget, but please be prepared for the next pandemic, of course, after this pandemic is taken care of. So that's what I would like to say. Thank you very much for your kind attention. Back to you, Dr. Siswanto. Thank you.
Thank you, Prof. Chandra. I think Prof. Chandra already explained the epidemiological picture of the COVID-19 in Asia, especially in Southeast Asia region, and how to respond and to anticipate the prolonged pandemic, also pasca pandemic. I think it's good. Thank you, Prof. Chandra. Now we move to the question and answer. Prof. Raina, are you still there? Prof. Raina is still on the board? Because there are some question for address to Prof. Raina. Oh yeah. Okay, I show the. There are three questions for Prof. Raina. The first one is from Rin Garcia. basically she raised the question on how to respond and to anticipate in case the COVID-19 to be the prolonged pandemic. For example, like 2 or 3 years. Yeah. And the second is the question from Miss Wigati Marsongko. She raised the question with regard of an asymptomatic COVID-19 or the person without symptom. So because this is very important in terms of how this can spread to other person. So basically she raised the question, the correlation between asymptomatic person with the epidemiological uncertainty, because our analysis of course from the PCR positive. So this raised this question. And then the last question is from Indonesia, from Pak Indro, raised the question that that's a case in Indonesia that in this pandemic there is some casualty of the health worker that affected by the COVID-19, and how is the role of epidemiology to prevent and to anticipate for the health worker not to contract with the COVID-19. Thank you, Prof. Reina. Please.
Okay, so the first question about how do we manage if the pandemic is going to go on for a number of years? We just have to keep using the non-pharmaceutical interventions that we have, face masks, social distancing. We have to expand testing, make sure we can test everyone who needs a test, and the contact tracing and the quarantine. Those are the things that are going to keep it under control. So I think in the longer run, there's going to have to be a balancing act between allowing people to go to work and do the things they need to do, and mitigating the risk of transmission that will come every time we bring people together in close contact. That's just going to be the reality of how it is, as I showed you in that last slide with the curve that showed the recurrent epidemics, basically. In terms of asymptomatic transmission, yes, there's still uncertainty around how much. I don't think there's any uncertainty about whether it occurs. Everybody agrees that asymptomatic transmission does occur. There's actually been a documented case where someone caught it from another person who didn't have symptoms. And there's been a number of systematic reviews that have showed that it's somewhere between 16% and 50% of all infections are asymptomatic, and that makes disease control very challenging because you can't identify who is infectious. In terms of the third question about healthcare workers, healthcare workers are at the highest risk because of the occupational hazard of being around in a setting where there is a lot of virus load on surfaces in the air. The evidence is fairly convincing now that SARS-CoV-2 is spread by aerosols. It's probably also spread by droplets and contacts, but the aerosol mode is, the evidence has accumulated, and that means that healthcare, it's the air that you breathe rather than what you touch or having someone, visibly splash in your face. So I think healthcare workers need a respirator if they're treating COVID patients, and until we can provide healthcare workers with adequate PPE, we will continue to see healthcare worker deaths. And healthcare workers are not a disposable asset. It's not like drugs or masks where you can just increase production in a factory. It can take a generation to replace healthcare workers. And when you get an outbreak in a hospital, you can have hundreds or thousands of healthcare workers in quarantine. So it's something that's in the best interests of everybody to make sure healthcare workers are optimally protected.
Yeah, thank you, Prof. Reina. Yeah, I think now we move to question addressed to Prof. Chandra. There are also 3 questions, Prof. Chandra. The first one is from our colleague Barion from the Philippines. He asked about the update of the vaccine development in more detail, but Prof. Chandra already explained this. Yeah. The second is the status of WHO in the position on how to see hydroxychloroquine for the COVID-19 treatment, because there something to be questioned. And the third one is how the WHO see rapid tests, yeah, the position of rapid tests on how to for detection of COVID-19. Thank you, Prof.
Okay, thank you for the question. Number 1, for the update of vaccine. Something on my screen, but I think I can be audible and can be seen, but something in my screen anyway. So for the vaccine, as I mentioned, the development is ongoing. I already mentioned about solidarity trial. So solidarity trial 1 is about the 5 arms of treatment, but solidarity trial 3 is about the vaccine. So we will see how the vaccine will evolve. That's the first one about vaccine. Number 2, we in Southeast Asia region, about I think 3 weeks ago, had a meeting with all of Southeast Asia region who are able to produce vaccine, that at least 3 countries, that is Indonesia, Thailand, and India, and we discussed where are they in their step for producing vaccine. So they have several experience, and some of them are making by themselves. Some of them are a part of the, for instance, the Oxford study and other studies. So we still have to wait until the latest development of this vaccine, and we do hope that that trial could get a good result in the coming time. That's for the vaccine. Number 2, for hydroxychloroquine, as you may know that in the in general, WHO has not yet recommended any medication for COVID in general, as the slide that I mentioned. So because all are still under trial. For hydroxychloroquine, is also one of the arm of the solidarity trial. You may remember that after the Lancet publication, then the WHO stopped that arm because it was mentioned it was harmful, but then later on the temporary stop then take out, so it still can be done in the trial. But later on, based on the last study in UK and other institution, we found out that the benefit of a hydroxychloroquine for severe cases in hospitalized patients is not appropriate. So for solidarity trial, hydroxychloroquine is no longer a part of solidarity trial. Having said that, it's only talking about cases in hospital. WHO has no specific recommendation for hydroxychloroquine on mild cases as well as the prophylaxis. We are still waiting for the further trial on the mild cases as well as the prophylactic. But for severe cases, it's no longer part of the solidarity trial. Number 3 of the rapid test, one of my slide, as I mentioned on 27th of May, for that is one day before Idul Fitri anyway. So our WHO recommendation is to make a diagnosis based on PCR. For rapid test, antibody or antigen, it's not for general use. But you can use under the umbrella of research or data collection. Thank you.
But Prof. Chandra, there is another question from participant. From the country with low capacity of PCR tests, so how to solve the problem? So there is actually a dilemma between PCR and rapid test based antibody based.
Yeah, of course, but we all know the issue of, I mean, one of the slogan or one of the dogma that we, not really dogma, but we use the test, trace, and treat. So to be able to control the epidemic or the pandemic, we have to find the cases, and after we find the cases, we have to trace to the contact and treat or quarantine the contact, and then treat the patient. So if we do not do the test, trace, and treat properly, we may not be able to control the pandemic. To be able for tests, the recommendation one is the PCR. Of course, country might have limited capacity, but the increased capacity to do the test for the appropriate people is one of the key important for country taking care of that pandemic. Over to you.
Okay, Prof. Reina, Prof. Chandra, thank you very much for the deliberate discussion. I think this we can take a lesson learned from the discussion that the epidemiology pattern is very important, and then from that how we anticipate or correlate with the best intervention on how to combat the spread of the COVID-19. So now we move to the second session. Yeah, is that? Yeah, Uli? Yeah. So my dear all participants, now we move to the second session. We have in the second session, we have two speakers, Mr. Panji Fortuna Hadi Sumarto from Pajajaran University, and then Mr. Panji Wibawa Dewantara. And Mr. Panji, put as Panji, but Panji Fortuna confirmed that they're not brothers actually. So Mr. Panji Fortuna Hadi Sumarto will talk the topic challenges in measuring epidemiological indicator for policy improvement in COVID-19. Mr. Panji is a lecturer and researcher in Pajajaran University. His field is in epidemiology and also in mathematical modeling. Yeah, I think that's very important. Yeah, on how to sharpen the analysis of the epidemiology. So please, Mr. Panji Fortuna, now time is yours.
Thank you, Pak Siswanto. I request permission to share my screen. I hope you can see my screen now. And so I was requested to give a talk on challenges in measuring epidemiological indicators for policy improvement. I think this is a particularly tough topic to cover, especially in 20 minutes, because two things. Because one, I have to talk about measurement of epidemiological indicators. And the second thing is I have to talk about policy improvement. So in the interest of time, I will just focus more on the selection of epidemiological indicators for policy improvement, because I think in the end we will see that the challenges in the measurements itself are pretty common and commonly seen in epidemiological studies and as well as in surveillance studies. So without further ado, the first question is, which epidemiological indicators? So Professor Chandra, just before now, he showed us this document from WHO, Public Health Criteria to Adjust Public Health and Social Measures. And among other things, WHO outlined 7 indicators to observe and to answer the question whether the epidemic of COVID-19 has been brought under control. So these 7 indicators are epidemiological indicators. So let's see each of those. So the first one is effective reproductive number. And the second one is incidence, defined as the number of cases. The third one is positive rate among suspects. The fourth, positive rate among influenza-like illness cases. The fifth is mortality, the number of deaths due to COVID-19. The sixth, hospitalization rate. And the seventh is excess mortality due to pneumonia. So these are all epidemiological indicators. So which one are we going to use? I think it's very interesting that COVID-19 has brought effective reproductive number and basic reproductive number into the world's attentions. Global leaders, the presidents, the prime ministers, they talk about effective reproductive numbers, but how are we supposed to estimate that? It's a very challenging indicator to measure, especially in the presence of low quality data. But outside of these 7 indicators, we have many other indicators of epidemiology. There are attack rates, secondary attack rates. So which one should we choose? Why do we choose one over another? So the next question is, what policy improvement? Why am I showing you this? Because different indicators may be useful for different policy dimension. And there are 3 different policy dimensions. The first one is policy outcome. So which outcomes, what are the goals of the policy that are intended to be achieved? So I show you here at least 2 goals, elimination or control. And the other one is probably very popular right now, is reopening the economy. For us in Indonesia, we call it how to enter the new normal. So which one of these goals is the policy goal? The second one is the content. So to achieve the goal, to eliminate COVID-19 or to control COVID-19 or to open the economy, what interventions, what policies needed to be in place? So for now, in general, we have 2 options. We can do pharmaceutical interventions or we can do non-pharmaceutical interventions. But because, as Professor Chandra mentioned earlier, we don't have any definitive pharmaceutical intervention at the moment. We have no drugs and we have no vaccine available to fight COVID-19. So we are left with non-pharmaceutical interventions. But I will show you later that we have plenty of options for doing non-pharmaceutical interventions. And for that, we will need epidemiological indicators as well. The last one, the third dimension of policy, is the process. This is not really related to epidemiology, but I will put this as the closing statement that in the end, epidemiology is a part of the policy-making process. So even though the process cannot be measured by epidemiological indicators, we have to be mindful that in the selection and in the measurement of epidemiological indicators, the policy process plays a part, and vice versa, that epidemiological indicators that we use can change or influences the policy process. So which policy outcome? 3 options. The first one is to control COVID-19. Defined as reduction of disease to an acceptable level, which can be a different question in itself. What is an acceptable level? And the second option will be elimination. That is to reduce the disease or the infection to 0 level, meaning there is no transmission left. And we can see, I'm currently in New Zealand, and New Zealand is selecting this second strategy, the second policy goal, to eliminate COVID-19 from the country. And the third one is reopening the economy. It is probably implicitly mentioned as any policy goal, whether it is to control or to eliminate COVID-19, that in the end, we want to be able to reopen the economy. But I think when we talk about reopening the economy without talking about elimination, that implies that we are satisfied with controlling COVID-19 until a level that is acceptable for public health. So here an example of New Zealand and Indonesia. So New Zealand proposed to eliminate or choose to eliminate COVID-19 from the country. And for the indicator of elimination, it was proposed to use just one indicator, which is infection incidence. So, and I have to underline this, that the indicator chosen was infection incidence, not disease incidence, meaning they need to have a very good surveillance. What about Indonesia? So I obtained this from a PowerPoint presentation from the COVID-19 task force. And obviously, or probably implicitly, the goal was to reopen the economy, or in other words, to control COVID-19 in Indonesia to a level that is safe for us to reopen the economy. But what indicators do we choose to use to evaluate the policy? We will see in the next box. Of course, we will have surveillance data to estimate the indicators that we're going to use. So what indicators? There are plenty. In total, there are 15 indicators, but some of them are health system indicators. But the epidemiology indicators are these. So disease incidence in absolute number, I mean the number of cases, but there's also disease incidence in rate per 100,000 people. There's case fatality rate, that is the number of deaths among those confirmed to have COVID-19. But there's also mortality rate per 100,000. In addition, we have hospitalization rate, recovery rate, positivity rate of testing, and then effective reproduction number with a note there that it's used to that it will be used as a supplement to other indicators. So we have 1, 2, 3, 4, 5, 6, 7, 8 epidemiological indicators. So which one is better? Having 8 indicators or just one? So this is a matter of options, but it goes back to the policy goal. Now, suppose we have a goal in mind. So what are we supposed to do? Which one of these interventions that we should do? We have plenty of options. Well, I said that we have 2 major options, pharmaceutical interventions, but we don't have those options right now. We have these non-pharmaceutical interventions potentially be used to fight COVID-19. It ranges from personal protection, just using hand hygiene, washing your hands, very important, practicing respiratory etiquette, wearing face mask or face shield, and then we have environmental measures, surface or object cleaning, disinfecting, using UV light, improving ventilation, modifying humidity. We have travel-related interventions like issuing travel advice or doing entry or exit screening, or up to making travel restrictions or closing borders. And in the end, I think we have these very popular interventions that everybody talk about in the past 3 months: social distancing or physical distancing, that ranges from contact tracing, isolation of the sick, quarantining the exposed, closing schools and workplaces, or limiting the number in crowds. So the question is, we have so many options here. Which one should we use? But before we go that way, just as an illustration, how recommendation or policy can change depending on not only the evidence, but on the interpretation of the evidence. So as a case of example is the use of masks in the context of COVID-19. So on its April 6, 2020 recommendation, WHO said that the use of masks for healthy people in community setting is not supported by current evidence. But WHO did not follow with specific recommendation, other than saying WHO offers the following advice, that the countries apply a risk-based approach. Why? Because there was limited evidence. There was limited evidence that masks can protect household members if there was a sick patient in the household, but there was no clear evidence whether it was useful to protect or to prevent disease in the wider community setting. But in their June 5th recommendation, they changed the position into recommending government to encourage the general public to wear masks in specific situations and settings as part of a comprehensive approach. So it's, I think this created some discussion and debate why WHO changed their position, although the recommendation stays the same. It's not yet supported by high quality or direct scientific evidence. But in addition to considering high quality or direct scientific evidence, there was also a mention of growing compendium of observational evidence and consideration of values and preferences, and also the contextual factors of difficulty of doing physical distancing. So this is a matter of indicators of efficacy and effectiveness. At the beginning, the WHO tried to see evidence of efficacy of wearing masks for preventing COVID-19. But in public health, this is such a very complex and complicated policy setting. We are more interested in effectiveness, because efficacy is different from effectiveness. In measuring efficacy, which is an epidemiological indicator, we usually use a very well-controlled environment, whereas in public health setting, in policy setting, we don't have that optimal environment, and of course, the efficacy usually reduced. So in the end, there are a range of evidence, epidemiological evidence, that can be used in policymaking in public health, as well as in COVID-19. It ranges from the very high and highly objective evidence coming from systematic reviews to a very subjective evidence, quote unquote, from personal experience and word of mouth or from the media. And we have to be mindful in here that we have to differentiate evidence-based medicine with evidence-based public health. In fact, I think, in my personal opinion, there is no such thing as evidence-based public health. There's probably evidence-informed public health. But what are the differences? So the first one is types and volume of evidence. So if we try very hard, or probably too hard, to look for high quality evidence of efficacy of certain intervention in public health, we may fail to find one because it's not efficacious, but because the volume of the study is just lacking. So probably nobody had done a randomized trial to test the intervention at the community level, at the programmatic level. So it's a matter of types and of volume. So in evidence-based medicines, we usually use individual level randomized trials, whereas in public health, we are probably more interested in looking at cluster level randomized trial. And the volume is just different. I think we can observe thousands of RCT reports, but far fewer cluster randomized RCT. But on the other hand, we have more observational studies and even qualitative studies in public health. So we may need to consider those in collecting evidence and measurement for policymaking in COVID-19. And then the type of interventions. Usually in high quality evidence that we often talk about, we only talk about a very simple one intervention compared to one or a little more than one control strategies. But in public health, we usually consider a range of options and a package of intervention. So yes, we consider the use of masks, and we also consider about physical distancing. We also consider object and surface cleaning, and we're still looking for vaccines and drugs. So what are the effects of having these combination of different strategies as opposed to having just one, probably less efficacious intervention? So it's very hard to infer effectiveness of complex intervention from just simple and single intervention efficacy study. The last thing
3 minutes left. Yeah.
Oh, okay, Pak. Thank you. And the last thing is that we need to consider the heterogeneity of users. For evidence-based medicine, the users are mostly medical doctors, but in public health, we have to speak with many different policymakers, including those considered lay people in epidemiology and in medicine. So one of the things that we can use to measure effectiveness is modeling, but there are a lot of challenges in doing modeling for COVID-19. First of all, we will be faced with options to choose simple or complex models. So complex models is more realistic and is more easily translated into policy. But with complex models, then it gets harder because we need more data. We need parameters that probably mostly are unknowns and it's currently unknown. COVID is a brand new disease. And on the other hand, the data that are needed to parameterize the models are probably lacking or of low quality or suffer from lots of uncertainties because of ascertainment, reporting delay, or inconsistent data collection methods. The last thing is, do you know how to do it? It's very hard. It's not easy. There are lots of options. And I think even for a country like Indonesia, there are not that many people who are able or have the technical capacity to build complex and satisfactory model for COVID-19. So I have 2 or maybe 3 slides. So I will be short here. In general, policy questions, data collection, and analytical methods must be aligned. So on the right side here, you can see that it's a cycle. So you have to define policy questions. You have to look at what data are available, and then you have to couple that with the scientific understanding and see if the available data can fit the scientific understanding. And if necessary, we add data by collecting new data, and then we can provide policy advice. In cases, and in most of the time, we don't have enough data from surveillance alone. So we need supplemental studies to add more data and to produce estimates required to measure epidemiological indicators. So these are examples. You can have household studies, community studies, case control studies, and also laboratory studies. So these are all important epidemiological indicators that we need to control COVID. So in closing, I would like to remind you about the policy process. So data availability, quality, as well as analytical methods are always a challenge in measuring epidemiological indicators for COVID-19. But I think in the academic world, we have plenty of new ways to estimate epidemiological indicators. So it's more important to ask which indicators do we want to measure. But we have to remember that the measurement of epidemiological indicators is a part of the policy process. So one last thing from me is that the public health policy against COVID-19 needs to be informed with epidemiological indicators. But there are some barriers and challenges in creating or in making evidence-informed public health policies. And I found this just recently, and I think it's very nice. So there are several issues that manipulating evidence. I think this has been raised many, many times. That some government hide some data. So it's an issue for evidence-based, evidence-informed policymaking. So to mitigate that, we should open all the evidence and nothing to hide. And then there's contextual differences. And for that, we need a clear methodology to assess generalizability and of the data, and also to develop methods that will fit with the data in hand. And of course, with COVID-19, the information and data flow is very fast. So what was valid a week ago is invalid this week. So I think we have to be vigilant, and we also have to share results and priorities with public at wide. So, okay, I think that's all I have, Sis, and I return the presentation, the forum to you. Thank you very much.
Yeah, thank you, Dr. Panji. I think this very interesting presentation. So, because you already present what we call policy scenario modeling. Yeah? So whether control, eliminate, or reopening the economy. I think that's a good discussion. Yeah. I mean, so kindly please for the attendee to raise the question or comment on this issue. Now we move to the next speaker. So the last speaker, the last but not the least. Now we go to Mr. Panji Wibawa Dewantara, PhD. He will talk about the geospatial analysis for the COVID-19 surveillance and intervention. As we all know that surveillance is the key of designing the appropriate and effective intervention of the COVID-19. Mr. Panji for Dewantara is our researcher in the NHRD in Badan Litbang. So his PhD also in geospatial analysis. Time is yours, Pak Panji Wibawa Dewantara.
Okay, thank you very much, Pak Sis. So I would like to share my screen. Yeah, so this is, thank you very much for inviting me as one of the panels, one of the speakers of this international webinars. So it's my pleasure to be part of this valuable webinar. And so today we have a great discussion on how geospatial analysis can be used to help control the COVID-19. So this is my talks, the outline of my talk today. So I briefly introduce you with what is the spatial epi and how its history and important elements and what the purpose of understanding the spatial epidemiology. And I'll give you a few illustrations on how existing studies that use such approach, and finally we'll discuss the use of such techniques in the context of COVID-19 in global and especially in Indonesia, which may gives you an ideas to further explore and understand COVID-19 epidemiology. So the first slide, I would like to talk about the story of John Snows. So everybody, especially epidemiologists, will know the story of how John Snows investigate cholera outbreak in London. So he's known as the founding father of epidemiology, and due to his way on solving cholera at the time has brought him become a pioneer of the modern epidemiology. In short, to solve this problem, as you can see in the slides, he did a systematic way, as we know, contact tracing and trying to collect data door to door and trying to ask people who has been contracted by cholera at the time and asking about people's behavior, what people drink, and try to map houses with cholera and pumps in the neighborhood. By looking to his map, it's clearly an obvious pattern that most people who had cholera were centered in the Broad Street and near to the pump. So on the right hand, so you can see the picture of the pump, which is John Snow had made a conclusion at that time and come to the local governments and said to the governments to remove the handle of the pump. So this is the, I think, the great legacy from the John Snow that has inspired us as epidemiology, learning and understanding patterns of diseases. So learning from that story, so the spatial epi, we can say that it consists of three important elements, which are epidemiology and data and how we analyze the data. I think in the past 2 decades, the field of spatial epi has emerged and growing rapidly and much become more relevant and useful in understanding the occurrence of disease and its risk factors. Simply, the objectives of spatial epi, these are a lot of benefits that we can have from understanding and applying the spatial epidemiology approach to understand the disease. Why is it so important? So spatial epi could help us not only to look at the pattern, but also to lead us to another hypothesis and about about why such pattern exists and what factors that might affect such distributions, which in the end will have a new knowledge and understanding on the epidemiology of disease. For instance, I'll give you an illustration. If we look on malaria cases, we found that malaria cases are spatially clustered in some way and at some area. We could have some ideas. We could have some ideas or hypotheses why those cases are clustered at some point. Our hypothesis may be that could be associated with the presence of habitats of mosquito or crowd settlements. Others, most importantly, maps can be also a media to influence policies. This can be a powerful tools that can inform health authorities in designing and implementing effective disease control and surveillance. So the next slide, I would like to share, illustrate the phases or the stage in doing spatial analysis. So the first thing that we need is, of course, the data itself, and we can get from routine notifications and even surveys. Additionally, we also need data for risk factors, for example, like climate, environment, and socioeconomic conditions for a particular area, which also we can get from any sources right now, such as reports, surveys, or even in this modern era, we can get freely from available big data. So the spatial analysis can be grouped into three phases, as you can see here. So the first one is the visualizations, which aim to describe patterns of diseases. And next, the later phase is to explore the pattern itself. Where is the clusters? Where is the hotspot of the diseases? And the last one, and I think the most important one and interesting in the recent days. So the modeling part, which is aimed to quantify and to assess the risk factors, how such factors can influence the distribution of diseases. And also it will help us to estimate how many people at that area which most at risk. So this slide gives you an example. Yeah, I give you a good example from Philippines. I know that today's webinars most audience is from Philippines. So these maps was generated by my mentors, my supervisors from UQ, and they did spatial modeling using Bayesian geostatistical analysis using in the household level survey data and trying to incorporate in various data, including environmental factors and socioeconomic factors that can produce, finally can produce the continuous surveys of prevalence of worms amongst boys aged over 20 in the Philippines, which I think it is an example that maps can inform health authorities, especially where MDA, the Mass Drug Administration, or water and sanitation and hygiene intervention can be applied. So this slide gives you also an example using, it's different with the previous one. So here I use the county level data, so an aerial data, and then trying to estimate risk at a certain administrative boundary. In this case is county, trying conditional autoregression modeling to find and to estimate risk of leptospirosis over the upper Yangtze River in China. And these maps trying to help local health authorities at that regions to improve, for example, One Health interventions to control human leptospirosis at that region. So the last examples is trying to look at and trying to predict the spread or distribution of leptospirosis in Western Java Island. So this is where I am now. So you can see in the edge of the Java Island. So here I am. In this study, we're trying to use ecological niche modeling to find the estimate of leptospirosis risks using a different scenario of climate from the available sources online. So now we move to the context of epidemiology for COVID-19. So as we may know, most people know now, there are a lot of GIS-based platforms that have been used to trying to illustrate the distribution of COVID-19, either both globally and nationally, including in Indonesia. So, and also the one example at the bottom, our institution trying to map at the lowest administrative units in Jakarta, which has helped local health authorities or task forces in determining appropriate measures and actions. So these are two studies from Italy and China using a quite interesting and interactive maps to try to help us to understand the spread and expansion of COVID-19 throughout the countries. So you can see on the right map from Italy, this is the dynamic map, interactive map to show us how COVID-19 firstly emerged in the top of the Italy, and then at certain time has extensively expanded throughout the Italy, which is, I think it's quite interesting and can help us to understand the nature of the COVID-19. So this slide show us the one examples at the local level, especially in the city of Rio de Janeiro in Brazil. They're trying to generate to generate a vulnerability index, an index that help to estimate and to classify where counties were at highest risk. They're trying to add several risk factors data, including population density, and then elderly population and TB incidence at census tract level, which is, I think it is also helpful for local health authorities to find and specifically target areas and estimate people at risk at census tract level and define and prioritize what intervention can be implemented at local level. So now I'm trying to share some preliminary findings from our project in regarding COVID-19 in Indonesia. So we from Spatial Epi Lab in our institute trying to help health authorities to provide the evidence base using spatial epi analytics. So we use confirmed case data from Jakarta, thanks to province of Jakarta to provide us with the data. And so these are a simple map trying to describe the spatial and temporal patterns of COVID-19 distribution at kelurahan level at kelurahan level over time during the first week when the COVID-19 emerged until the week 14. It's just before the restrictions is lift up or move towards the transitions. So from the map on the left, we can see that the incidence and mortality rates were geographically heterogeneous at kelurahan level. This may suggest that variation in COVID transmission risk, which may lead us to another hypothesis, which are such as what are factors, environmentally and socioeconomic factors that may influence such patterns. And this picture also could help to and could reflect the variation in testing rate, especially because we have a lot of uncertainties in the field. So we can also interpret this from the epidemiological point of view, that there may be a variation in testing rate or surveillance coverage or capacity across Jakarta, which can result in variation at kelurahan level. So by this, I mean that darker areas could be having more tests than others, not necessarily epidemiological relevant, but which this could be biased. And finally, our interpretations. So you can.
Panji Dewantara, so 5 minutes more. Yeah?
Okay, so thank you. So from this map, we can have a hypothesis. Why does it vary across Jakarta? Are there demographic factors or mobility or even behaviors at individual level? So this map also shows us the patterns over time, how many hotspots in Jakarta. So we found that 19 hotspots over the week. So, and we estimate that more than 400,000 people were affected by COVID-19. So what do we need to do? So maybe the first one is improve surveillance, improve preventions, and maybe from this map, we could inform local health authorities to take necessary intervention for those identified hotspots, like isolation or distributing much more testing or tracing. So the next stage, we did a map. We did mapping, knowing known risk factors associated with COVID-19, such as factors that can be derived from any reports, even big data. So here we map, for example, sex ratio, density, and then age compositions at kelurahan level, and also road density at kelurahan level. And then we built a spatial Bayesian model to further quantify the effects of such variables on the variation of COVID-19 at kelurahan level across Jakarta. So from this analysis, we simply found that the age compositions and population density indeed influence the variation in risk of COVID-19 across Jakarta. So I think the last thing that I want to share, that maybe such case study can give us some thoughts after these discussions, and maybe work to discuss how can such geospatial analysis be part of policymaking, especially for COVID-19 control. We try to formulate a framework that maybe can help ministries or authorities to use these such techniques to help them to make a good and better decisions. So there are challenges and also opportunities, especially how we manage the quality of the data at the field, and also privacy issues, and most importantly, how we can translate our maps, these maps, into policy. That's the most important one. So, but we have a lot of opportunities in today's era, like big data and then advanced spatial analytical tools. Their society consists of geospatial analysts and data scientists that can be involved in larger project and trying to help governments to make a good policy. So I think this is the conclusion from my talk. So you can see that disease is indeed a special phenomenon. Understanding where could help us to understand and explain why does it exist, and what public health measures that we need to adopt, and including if we add a time variable in our modelings, in our analysis, we can use that time factors to prevent the fatal outbreaks in the futures. and most importantly, improve surveillance, and then will improve maps, and finally will improve policies. And the most important one is, I think, to control COVID-19, we have to do a lot of works and collaboratively and trying to involve multidisciplinary expertise and trying to tackle COVID-19 in Indonesia. I think that's it, my presentations and my talks today. And thank you, terima kasih, and hatur nuhun. So this is our labs, Spatial Epi Lab in Pangandaran Research Station. So thank you very much.
Yeah, thank you, Panji Dewandara. I think he already explained the importance of time spatial analysis for in epidemiology to make better decision on how to combat the spread of the COVID-19. My dear, or the attendee and participant of the these webinars. So now we move to the question and answer session. There are a number of questions that raised by the attendee. Many questions, some question addressed to the Dr. Panji Hadi Sumarto. Yeah. The first one is from our college in I think it's from Philippines maybe. Yeah. So the question is, let me see. This one. So how to use the artificial intelligence for handling COVID-19 to make scenario policy modeling with with not the complete data, like maybe Indonesia also one of the example. That's the data is not so easy, also not so complete. So how to make this? And the second issue is from our colleagues from the Philippines. So just to clarify, the question is basically to clarify what Pak Panji say about the data who are deliberately manipulated. So basically, it's just to clarify what you mean. And the other question is how how maybe like Indonesia also there is some area there is not zero cases, but the government want to implement what we call with new normal, adjusting the new behavior. So that's and the last question is from Pak Pandu. I think that's from World Bank. Also raise the same question with the lacking of data and how to make the best modeling for the policy input. So please, Pak Dr. Panji Hadi Sumarto, to respond that question. Thank you.
Thank you, Pak Sis. I will try to answer the questions to my best. So for artificial intelligence, I think the first thing is that I'm sure there is no such a thing as a complete data set. There's always missing data, missing information. But first of all, I'm not an artificial intelligence person, so I don't know if I qualify to answer this question. But I think the question is for what purpose? So I think what you meant for handling COVID case, probably something like to grade the risk for severe disease, something like that. Yes, I don't think there is complete data set, but right now I know that the task force is the center for all the data for COVID-19 in Indonesia. I don't know what kind of what are the variables that they have and what's the quality of the data set, but I think if you are interested, then probably you should get in touch with the national task force. And also for clinical cases, I'm sure you will need supplementary data set from hospitals and from health facilities, because I'm sure they will have more data, more information about cases. For the second question, so just to clarify, I did not say that anybody manipulated any data, but it was being discussed in forums, in groups, and of course, it's probably an accusation, a very serious accusation, and that's why we need to prove it. And I think we can prove it or disprove it by collecting good data, doing good analysis, and presenting the results to the public. So I think with good data analysis, with good data collection, we can show whether the data are manipulated or not, and then we can correct for the manipulation if there was any. And then for new normal, that's a very good question. I think this has been hotly debated. For now, we're using effective reproductive number. I know that the Ministry of the National Development Planning is using and creating a dashboard for effective reproductive number for provinces and cities in Indonesia. But I think it's very hard because for some cities, there are very few cases that makes estimation of RT is impossible or unstable. What I personally prefer is the approach that New Zealand used in measuring the control effectiveness, the effectiveness of control of COVID-19, which is estimating the incidence of infections. But for that, we are going to need a very good surveillance system and very good capacity for testing. And the last one is best modeling approach. That's a very good question, Pak, and very hard to answer because I think to produce a good model, at least a good enough model, then two things, Pak. It's a matter of structure. And when we talk about structure, we need to know, or we need to have good knowledge about the disease itself, how it's transmitted, who are at risk, and how mixing patterns will affect transmissions. And the second thing is we need data to parameterize the model. But I think, in my opinion, if we want to produce a good enough model, then we don't have any choice but to have the data required to produce such models. So I think what we need to discuss, if we want to have a good model, then we need to figure out what kind of models that we need to answer specific policy questions, of course. And then we need to figure out what kind of data that we need to parameterize the model, and then collect those data, make sure that the data that we are using to parameterize the model is a good one. Thank you, Pak.
Thank you, Dr. Panji. Now we move to another question. There are two questions for Pak Panji Dewantara. The first question is from Mr. Mujianto from the Research and Development Center of Vector. So the question is, what is the limitation of the spatial analysis or mapping effectively during the COVID-19 pandemic season like now? It means that we have a difficulty, we had barrier to get data from primary healthcare, from and so on, because of work from home and then physical distancing and so on. The second is from Mr. Sitik Purwoko, and then the question is how we can align the result of spatial data analysis with the other data from the various sectors. I think that's a kind of how to integrate our analysis with the another sector. Please kindly to respond, Mr. Panji.
Yeah, thank you very much, Pak Sis, and thank you for the questions. So I'd like to answer the first questions from Pak Mujianto. What sort of difficulties or challenges in mapping COVID-19? So the first thing is, of course, the data itself. So we have difficulties in collecting data especially a high resolution data, for example, like case data, individual level data, which with its characteristics, because I think if we can use a good and high resolution epidemiological data, we can help to produce maps and predictions better, and which can inform policymakers. So I think the first one is in collecting data, especially with trying to for example, in Jakarta, and also we also doing analysis on the East Java in Jawa Timur. So we have to trying to some of approaches. For example, we have to send a letter to get the permissions to collect the data itself. And the other things, beside the data itself, it's a lot of uncertainties. So, for example, we have to check whether the quality of the data itself is good or not. So that's why we just limit our analysis for laboratory confirmed cases, not include the suspect or probable cases. So that, I think, the two most important challenges and difficulties when doing mapping and trying to analyze the spatial distribution of COVID-19. And the second one from Mr. Siddiq, how we can align or integrated another data from another sources into our analysis. So the first thing in the spatial analysis, we have to set up and determine what is the spatial unit of analysis. The unit of analysis, is it kelurahan level or county level, or even province level? So you have to find some sort of data that match, that can describe at those the unit of analysis. I think that's the most important one. So, and trying to find a lot of more data, including risk factors that which known from literatures or published papers, and also from our understanding about the epi of COVID-19. So you can find, for example, mobility data from Google Mobility or Facebook even, and then you can also use reports from statistical bureaus and match that data into our unit of analysis, whether it is county, kelurahan, or kecamatan, or even province level. I think that's my answer. So thank you.
Thank you, Pak Panji Dewantara. So I am, as a moderator, also want to raise the question to Dr. Panji Hadisumarto, actually, because your presentation for me is very interesting. You make a contrast between Indonesia, an example, opening economy with the strict health protocol, and then the other is New Zealand. That's elimination. So my question, what is your opinion about to choice of the policy scenario model? Which one you prefer, actually, as the policy analyst?
Thank you, Pak. Very interesting question. And I think it's very difficult to answer, especially right now. Had you asked me 3 months ago, then I would say we should go for elimination, because we had a chance, because there was not that many cases. And if we ramp up, we increase testing capacity and improve our surveillance capacity, then we may have a chance to eliminate COVID-19 even from Indonesia. But I think at this point, it's very hard to say that we can aim for elimination. elimination. I think aiming for control is a good thing, good enough thing, but it's also going to be hard. So naturally, the next question will be, if we are not able to eliminate COVID-19, then how are we supposed to open the economy? So I think I adopt two situations. So I think policymaking is highly contextual. But I gave you an example of New Zealand and Indonesia because they are contrast. So it's a contrasting examples. But I'm not saying that at the moment, one of them are more correct than the others. Of course, we have seen that the results are different, but I cannot say that Indonesia is incorrect or New Zealand is more correct. Of course, New Zealand is in a good condition right now, but well, it is what it is. So I think, Pak, what we can do now is to make sure that we still have the capacity to, we have the indicators and measure the indicators well to make sure that this is not merely rushing up to open the economy, but to make sure that safety and control of COVID-19 can be achieved, Pak. I think that's my opinion, Pak.
So you want to, you want to say that epidemiology should be the leader and the others must follow, something like that?
There was an article I read, Pak, in the paper online. Let's say why epidemiologists can never agree with economists, because for epidemiologists like me, like us, probably there is no trade-off. Health above all. But yes, well, I learned about policy making as well and political economy. But I think there should be trade-off. But the question is, what kind of trade-off, Pak? And that's difficult to answer.
I do agree with Dr. Panji. So basically, policy choice is a trade-off, But on the crucial point is how to choose the best mix of the choice in such a way that beneficial for our people, and I think that's very important. Agree, Pak Panji. So I think we, all of the, all of the question already be respond, and then we have a deliberate discussion, good discussion. Yeah. So let me summarize. Yeah. Let me summarize before we end this webinar. Yeah. So there are 4 important points actually for this discussion, for this webinar. The first one, that the epidemiological pattern trend, and the epidemiological pattern and trend of COVID-19 is very important, to make a better decision, and that's need complete and valid data. It's need complete and valid data. And the second, that we can make a correlation actually between the epidemiological pattern of COVID-19 with the choice of the intervention, That's a presentation of Prof. Reina. So that kind of correlation between epidemiological pattern and the choice of intervention can be used as a lesson learned, for any country to have a better decision. And the fourth is that it is very important or useful, to make a scenario policy making, like what Dr. Panji present. So to make a better decision, and then we analyze comprehensively in such a way that the decision that we choose is beneficial for the people. So the end is basically the people. And the fourth, that's the analysis of time and spatial analysis of the epidemiology of the COVID-19 is also very important, in such a way that our decision on to make a relaxation of the social distancing is in a better in a better way, in a better choice, in a better decision. My dear all attendee and all participants and distinguished speaker, so I would say that thank you. I thank you very much for your participation, your deliberate discussion, and we hope that from this discussion that will be very beneficial, yeah, in terms of how we do further research, also on how we make a better decision on how to combat the spread of the COVID-19. So again, this is the first series of webinar, and there is another upcoming series of the webinar that is conducted by NIHRD, Ministry of Health. So again, thank you, and time to back to MC, Mr. Uli Adi.
Okay. Thank you, Dr. Siswanto, for your kindness as the moderator for this webinar, as well as our distinguished speaker for their shared knowledge and experiences. It has been a very interesting presentation and discussion as well. So, honored guests and audiences, ladies and gentlemen, thank you for your participations in this event. As our moderator have announced that this is the first series of webinar, so please stay tuned to our social media on YouTube, Facebook, and Instagram for the upcoming webinar series. And I would like to remind all of you about the evaluations form. Kindly not to forget to fill it and give your full name and valid email address for certificate purposes. The evaluation form can be accessed through the bit.ly link evaluations-webinar-25 June 2020. So as the moderator ended our sessions and our discussions, so this is the end of our webinars series number 1. Thank you for all your participations again, and thank you for all your interested in our webinar series. So we now end this webinar. See you next event. Bye.